Good evening and welcome to the RowanSOM Alumni Association's quarterly webinar series. I am Tom Cavalieri, Dean of the Rowan University School of Osteopathic Medicine. We are pleased to continue the alumni webinar series, which is now in its second year. Tonight, our expert panel will revisit the topic of COVID-19. This is certainly an area that the webinar series has addressed a number of times, directly and indirectly, and a medical topic that remains relevant for all of us to stay informed, lead healthy lives, and take precautions that we know will protect our loved ones and ourselves. Of course, when the Webinar Advisory Council planned this program earlier this fall, they could have not known that a brand new variant would be discovered and announced to the world just days before this session. But what they did know is that COVID-19 is not over, and in fact, the virus continues to evolve, and therefore we must adapt and learn how to live safely with it. Today's webinar, COVID-19 Updates and Treatments, will feature a two-physician presentation to address a wide variety of topics, including pediatric and adolescent COVID-19 vaccinations, vaccination versus natural infection, new oral medical treatments for COVID-19 infections, and the new Omicron variant. Let me thank our presenters in advance for not only their expert presentation for the original intended objectives for the evening session, but also for their ability to quickly study and share what we know about the Omicron variant. The format of the webinar includes an update from our physician panelists, followed by Q&A from our attendees. As a reminder, you may submit your questions at any time in the chat so they can be shared with the panelists during the session. It's now my pleasure to introduce our presenters so we can get this program started. First, I'm happy to introduce Dr. Michael Barnish, who newly joined our Division of Infectious Disease in our Department of Medicine. He is an associate professor of medicine here at our School of Osteopathic Medicine. As you know, he's a specialist in infectious disease, certified in internal medicine and infectious disease, but also certified in travel medicine by both the American Society of Tropical Medicine and Hygiene and the International Society of Travel Medicine. Dr. Barnish is a fellow in the American College of Osteopathic Internists, and we're really happy to have him tonight and also for him rejoining our full-time faculty. Also, we're happy to have Dr. Ashgan Elshinawy, a RowanSOM class of 1999. She's a pulmonologist and sleep medicine specialist. She runs a medical practice in Middlesex County, Pulmonary and Sleep Disorders of New Jersey. Dr. Elshinawy is a RowanSOM Alumni Association board member. She leads the Alumni Webinar Series Committee and has served as a panelist on two previous COVID-19 related alumni webinars. We are extremely proud of her and the great things she's doing for our school and for the patients entrusted to her care. Finally, I am pleased to introduce student Dr. Melvin Ways, a member of the RowanSOM class of 2023 and president of the RowanSOM Student Council, who will assist with the question and answer portion of the program. Thank you, our panelists, for lending your time and expertise this evening to address this very important topic. Now I'll ask Dr. Elshinawy to start the program. Ashgan?
Good evening. Thank you so much, Dr. Cavalieri, for that introduction. I really appreciate you joining us. Alrighty, so for everyone who is here, thank you very much for taking time out of your busy schedules to join us today for what is hopefully going to be an informative session about COVID-19 and where we are this many months into the pandemic. As Dr. Cavalieri mentioned, this is not our first COVID webinar, and I'm afraid to say it probably is not going to be our last. I was hoping the last one was going to be my last, but it didn't work out that way. But anyway, welcome again, and let's start. So at the beginning, I would like to start with some terminology. I want to just throw out some vocabulary terms for our class here today, and so that we're all on the same page, because Dr. Barnish and I will be using these terms throughout the next 45 minutes or so, and so that you all understand what we're talking about in scientific terms. Okay, first term, fully vaccinated. I know we've all used these words all throughout the pandemic, but we may be using them not so correctly. So fully vaccinated means 2 weeks after your second Moderna or Pfizer shot, you're considered fully vaccinated, or after your single Johnson & Johnson shot. And as of now, a little over 80% of Americans have received at least one vaccine. So we're not in terrible shape. Could be better, but we're certainly doing better than we were 6 months ago. The term reinfection, what that means is that you get infected after a previous infection while unvaccinated. So you never got any shots, you got an infection, recovered, and then got an infection again. That's called reinfection. As opposed to the term breakthrough infection, there you have been fully vaccinated, okay, and then have an infection. But it's an interesting term because it's been used so widely lately on social media, in the press, and breakthrough infection is still rare, but it's still happening, and I'm certainly seeing it in the office and in the hospital. And just so to shed kind of some clarity on it and perspective, any positive COVID test, whether you're testing yourself before you board a flight, or you're testing yourself for school or work because of a mandate or something, or because you have symptoms, any positive test means a breakthrough infection if you were already vaccinated. So the majority of patients who have breakthrough infections have actually been asymptomatic or have mild symptoms. Having said that, there are still some patients who are fully vaccinated and have serious infections with COVID, and they land in the hospital. They're the ones that we see when we do pulmonary and infectious disease rounds, and they're quite sick. And we'll talk about that, and Dr. Barnish will touch upon that, why that is happening, why we think that is happening. Okay. Now, the next term I want to talk about is transmission. That means the ability of one person to spread the COVID infection to another person. We do know that vaccinated people are 2 to 5 times less likely to transmit the virus to others. There's a study that came out of the University of Illinois that showed that vaccinated people shed less virus, stop shedding the virus a lot sooner than unvaccinated people, and shed less infectious particles than the unvaccinated. So vaccinated people, if they get a breakthrough infection, are contagious usually for 3 to 6 days, whereas unvaccinated people can transmit a virus for up to 18 days. So it's a huge difference. So another pro for vaccination. Now, the word immunity means protection in your immune system against this infection. And Dr. Barnish is going to be discussing this and the terms natural immunity, vaccine-related immunity, and hybrid immunity. So I'm going to just wait until he discusses it, and then we can go over it in more detail. One of the other final terms is booster, and all of us have heard about booster shots over the past 2 months. And booster is considered the third shot if you've already gotten Moderna and Pfizer, or a second shot if you've gotten the Johnson & Johnson. And know that you can mix and match these shots. So if you got Johnson & Johnson first, you can get a Moderna second. Pfizer, Moderna, Pfizer, you can mix and match. And there's a theory that perhaps there's actually a stronger immune response if you do mix and match, but you're certainly not required to do so. Now, the last term I want to go over before I turn to Dr. Barnish is long haul COVID. Long haul COVID are when someone gets infected with COVID infection and has residual symptoms that last for more than 6 weeks. And those usually include fatigue, shortness of breath, loss of taste and smell. Those are the more common symptoms that we're seeing for weeks to months after the initial infection. Interestingly, there's 30% of adults actually end up having long haul COVID after they've been infected, and only 7 to 8% of children have long haul. The interesting point is if you're vaccinated and develop breakthrough COVID infection, you're much less likely to develop long haul COVID. Again, another positive behind vaccination. So I think one of my bottom line things, take home messages today is COVID vaccines may not be 100% protective against COVID infection, but it should help prevent complications from COVID infection, long haul symptoms, as well as death, of course, and major complications, which again, we'll go into a little bit more detail. And now I'd like for Dr. Barnish to talk about what I think a lot of you tuned in today to talk about, to hear about rather, and that's our new variant that we've heard about over the past few days. Dr. Barnish, if you will.
Thank you, Ashgan. Good evening, everyone. Well, there's one thing that is certain about the Omicron variant is that we will know a lot more 7 to 10 days than we do now. That's for sure. We know very little about it. Obviously, the big concern is basically the number of mutations. And with these mutations, the inference that the vaccines we have may not be effective against it. That is a big concern. And that's why we have the panic or great concern that we have with it. This was first found in a patient in Botswana on November 11th, and actually it was somebody from South Africa. And after that, there was a cluster that first started in Pretoria among a bunch of university students coming back from the West Cape. And it was quite readily sequenced, which was a little bit unusual. But from there, we've seen a significant exponential increase in the number of cases in South Africa, which is suggesting how contagious it is. Since then, we've seen cases pop up in Europe, Israel, Canada, there were 2 cases, and in many other places of the world. Interestingly enough, not here yet in the United States, although it's hard to believe, and likely it is here. We will ultimately find it. The interesting thing is it's not hard to detect. It's very easy to find. The PCR test almost lights up like a Christmas tree. The typical COVID strains we see, including Delta, have 3 channels, whereas the Omicron is unique, having 2 channels on the PCR. So for people who are tested, we know immediately that this is the strain we have. It is felt that this strain probably developed, according to South African physicians, in an untreated advanced AIDS patient in South Africa who had very low T-cell count, was not on medications, and was COVID positive for over 200 days. And it was suspected that this gave the virus an opportunity to mutate in this person. What we know at this point is that while it is highly transmissible, and some feel it is 350 times more contagious than Delta, the cases so far have been all very mild for the most part. Most of the cases have been in young people, and really no hospitalizations to speak of. The symptoms primarily are malaise, muscle aches, fatigue, and a dry cough for about 1 or 2 days, and that's basically it. So obviously, we're still waiting for the fallout, and the full effect won't be seen for another 7 to 10 days. But whereas there's a lot of alarm about the transmissibility and the potential mutations that can cause potential decreased effect of the vaccines, the bottom line is right now we're seeing very mild symptoms. And there's certain ways viruses behave. You have some like Ebola that are not very contagious, but have a high death rate. And then you have others like chickenpox or measles that are very contagious, but don't have a high death rate. And usually it's one or the other. And right now, the suggestion is this may be very contagious, but may not be very significant. And there was one Israeli epidemiologist today who said this may, and I'm being very optimistic, this may actually be the beginning of the end of this pandemic, because most viral outbreaks or pandemics don't go away because we have a perfect vaccine, but it actually peters out and becomes just another coronavirus. So there is a hope that this may represent the beginning of the end of a strain that, although it has a lot of mutations, the virus has mutated itself out of being very aggressive or serious. We can only cross our fingers with that. It's too early to tell, but so far that might be the case. One of the concerns we have is that how do these mutations impact efficacy of the vaccine? There's an insane amount of mutations. For example, the Delta variant had 9 mutations compared to the original one. This has over 52. And 32 of those mutations are on the spike protein to which the vaccine is targeted, 3 vaccines we have. And the spike protein is what allows the virus to get into the cell. So 32 of those 52 mutations are on the spike protein. We do, however, have some precedents for some of the earlier variants that really didn't take off because they weren't that contagious or overtaken by Delta, which was much more contagious. But the Beta, Gamma, and Delta variants had mutations that, in essence, rendered the vaccine not as effective as the initial strains and even the Delta. And even with that, people who were vaccinated who got exposed to those strains still showed decreased illness. So there was a suggestion that even with the mutations affecting the vaccine, there was still evidence the vaccine did protect somewhat. And we feel that theoretically, the Omicron variant may be susceptible somewhat to the vaccine and people don't get as sick. One of the things we have going for us, especially with the mRNA vaccines, is due to their technology. It takes very minor tweaking to change the vaccine to protect against new variants. And already, since this variant was first found less than a week ago, Moderna and Pfizer have already begun altering their vaccine. And with these alterations, in theory, in all practicality, in 6 weeks, we can actually have a vaccine that will protect against this variant if we need it. And I stress that if we need it, because again, if this virus does not turn out to be a severe one, we may not need another vaccine. But if we do, we are positioned to have a vaccine in place in as little as 6 weeks. So that's the good sign about this. So very little we know about this, and that's because it's only been out. Hospitalizations tend to lag behind cases, and so it's going to take about 7 to 10 days from last Friday to see if we start to see significant hospitalizations. There is somewhat of an uptake in South Africa, but we're not really sure how much of that correlates with actual disease. The other good thing is most of the people who have the Omicron variant in South Africa have not been vaccinated. Only 35% of the country has been vaccinated. It's not because there's a shortage of vaccine in that country. It's because most of the cases are in young people and they have not been getting the vaccine. But those who are infected with the variant, 65% unvaccinated, 30% partially vaccinated, and we're seeing only mild cases. So I think there's been a lot of alarm unnecessarily because of this. I think it was based on the fact that it has all these mutations. That's a potential problem. But in reality, right now, what we're seeing is a mild infection with this variant. And hopefully that will stay that way. So I'll go back to you, Ashgan.
Thank you, Dr. Barnish. Just had a quick follow-up question about something you said. You were pointing out that the very, very early data in South Africa shows mild disease so far with the Omicron variant. Do you think part of the reason, besides, of course, the younger age groups, do you think that it's partly because a lot of the population already got infected and has some natural immunity? Because we see statistics where Africa, especially South Africa, has about less than 40% of their population immunized, but so many have been infected because they've seen some crazy surges in COVID. We could talk about vaccine equity and all access, but the bottom line is a lot of them have not been vaccinated. However, a lot of them did get infected. And is that why they're faring a little bit better with the COVID, the new variant?
I think that's a possibility. And I think that would also be applicable to the United States, because even with the vaccination we have now, there are studies that suggest that up to a third of all people in the United States have had the infection and never knew it or weren't tested. So if that were the case in Africa, you could actually make the argument here that if it ever comes here, there's enough people that have somewhat immunity. But in reality, I think it's more because of the mutations created that's made this disease less virulent. And that's the pattern we've seen, that a lot of these viruses mutate themselves out of relevance. And I think that's as likely as herd immunity, so to speak.
Thank you. And that's exactly why I brought up that question, because of the United States having such a high vaccination rate, as well as, unfortunately, a high infection rate in the past year and a half. So I'm hoping that bodes well for us in the coming weeks to months. So, okay. Thank you so much for that. I'm going to transition to our next section, which is talking about vaccines, the most recent approval of vaccines for children, which has been long awaited by many parents and grandparents all over the country. As you know, previously we've had the age group 12 to 15 years of age being approved for vaccination. After a few months, we noticed that only about 45% of children in that age group in the country have been vaccinated, which is kind of dismal. I was hoping for more, but for some reason that age group is not being vaccinated at the rates that we would like, especially since they're going, in middle school and high school and in kind of close congregates with each other. But that's the fact right now. Currently, as of a few weeks ago, we had the approval by the FDA for 5 to 11-year-old children to get the Pfizer vaccine. And for those of you who are still thinking about getting your kids vaccinated and just want to know a little more about it, they are basically using a third of the dose that they gave to us, the adults, for these children 5 to 11, okay? They did a trial that involved 2,400 children between the ages of 5 and 11, and they gave most of them vaccines and they gave some placebos, and they came out with the results that the kids that got the vaccines, very few developed COVID infection, whereas in the placebo, the ones that did not get the vaccine, a lot more did have the COVID infection. So it was a really good, it was over 90% effectiveness for this vaccine for children. And it was approved, and they ended the trial early, actually, because they didn't feel it was ethical to continue giving children placebo when it was very effective, and it's been shown to be very safe as well. And now I tell parents who ask me about whether they should get their children vaccinated because they're concerned. Obviously, it's a new type of vaccine, and they're asking me about the risks and benefits. And I tell them basically it's twofold reasons why you should get your child vaccinated. And one is you want to prevent the infection and the disease in children, along with the complications, the very rare complication, but we still see a complication of the what's called MISC, which stands for multi-inflammatory syndrome in children, which has included kind of a all body inflammation, including myocarditis and pericarditis, which is severe inflammation of the heart linings. And some children have died of it, not commonly at all, thankfully, but some kids have still been reported to suffer from these complications many months out. And if you recall, I previously talked about long haul COVID, and up to 8% of children who develop COVID, even if they had mild symptoms, they have the mental fog, the fatigue, the aches and pains, the loss of smell and taste for many weeks and months later. So I wouldn't want that for any of the kids. Now, there was this one thing that came out that a lot of people were talking about and concerned about, the advent of myocarditis and pericarditis from the vaccine. And although it was published by Pfizer that there were some children that developed myocarditis and pericarditis from the vaccine, when they compared the risk of developing that complication from the vaccine versus developing it from the actual COVID infection, it was night and day. So the numbers that they came up with is there's 1 in 45 cases of myocarditis from kids that had the infection, whereas the kids that got the vaccine, the cases were 1 in 20,000. Basically what that means is you're much, much less likely to develop myocarditis or pericarditis from the vaccine than you are from the infection. Also, the data showed that it mostly affected boys in the age group between 16 and 25. So it didn't even affect any of the children between ages 5 and 11 in that trial that they did. Also, the other promising detail is that the children that did develop that side effect from the vaccine, it was a reversible process. So their inflammation of the heart did resolve on its own, whereas children who developed it from the infection can have a much longer course of that complication. And as far as we know, it may not resolve. We need more data and more time to pass for us to really know that. Okay, so the common side effects from the vaccine, I tell parents, are the ones that we experienced when we got the Pfizer or the Moderna vaccine. Low-grade fever, a sore arm, fatigue, usually not lasting more than 2 days. And there have been reported no long-term side effects. And we know from the long history of vaccines that long-term side effects beyond 2 months don't really exist. Any side effects that you're going to get from a vaccine, you're going to usually see within the first few days, but definitely within the first 2 months. Okay, and so far, I think in the first week we had more than 1 million children vaccinated between the ages of 5 and 11, and there hasn't been a single reported case of a complication from the COVID vaccine. And there are just a couple of things. The NIH, National Institute of Health, has begun a long-term study of effects of COVID-19 on children and young adults and ages 3 to 21, looking at their risk factors, their immunity, their complications, so that they can answer more of the questions that parents, the really good questions that parents are having. But all in all, the vaccine looks very promising, very safe, and very effective in children in this age group. And I would encourage everyone you know who has children in this age group to go ahead and talk to their pediatrician to see if they're a good candidate for it. Okay. Now I'm going to go back to Dr. Barnish, and if you can discuss your section on immunity and what we need to know about different types of immunity to COVID.
Sure. So one of the biggest ongoing debates concerning COVID is whether natural or infection-induced immunity is stronger and lasts longer than vaccine-induced immunity. And the people voicing this the loudest are not those who've never been infected, but rather those who've already had the disease and are questioning the need for being required to get the vaccine afterwards. With evidence that vaccine-induced immunity is clearly waning after 8 months, as witnessed by the marked uptick in cases since the spring, including those who've been vaccinated, we are seeing an increase in requests to have antibody tests checked to see if people have already had the disease. So there's still many unanswered questions about this issue that only the test of time will determine. First of all, we need to know the vaccines do work in preventing severe disease and deaths. And most people argue is that was the goal of the vaccines, not to prevent disease, but to prevent severe disease, hospitalizations, and deaths. Unvaccinated persons are 12 times more likely to be hospitalized and 17 times more likely to die than vaccinated persons who contract the disease. And I think we can all agree there has been more than enough studies showing the vaccines are safe, including in younger patients. The blood clotting and thrombosis risks are small and were found in well-defined populations. Dr. Elshinawy already mentioned the myocarditis and pericarditis aspect of it. We don't see that with the J&J vaccine, and again, the clotting factors in a small population. So overall, outside of the initial side effects some people get with the vaccine, they are safe, including those in pregnancy. So how does natural immunity compare with vaccine-induced immunity? What is the reinfection rate following infection? How does it compare with breakthrough infections following vaccination? Well, reinfections have been found to happen twice as much in previously infected and unvaccinated persons compared to vaccinated persons with breakthrough infections. And hospitalizations are 5 times greater with reinfections over breakthroughs from vaccines. So there clearly is a difference. Possible reasons for this are that the initial infection was not due to the Delta variant, so there are few, if any, antibodies present to fight the new strains. And this certainly may apply to the Omicron variant as well, given all the mutations that are associated with it. And there's evidence that those who had initial mild infections may not have developed antibody levels high enough to avoid reinfections. And those reinfections can actually be more severe the second time around. So there's a lot of people who don't want the vaccine because they said they had COVID, it was mild, they're not afraid of getting it again. But for that reason, it may be problematic the second time around. The good news is that the overall reinfection rate is pretty low. It's on the order of 0.4% or 4 in 1,000. And the odds of severe disease following reinfection is a very low 0.1%. We do know that all the vaccines are effective against the Delta variant as it stands now. And with all the talk of the Omicron variant now, it's pretty important to remember it's still Delta that is accounting presently for all the cases in the United States and the hospitalizations in this country. And we really can't get distracted about that. There's a question about why should we continue to push for the boosters because Omicron is coming. But right now, we're still dealing with Delta, and the hospitalizations are an issue. And that's where our emphasis has to be for now, especially if Omicron doesn't pan out as being anything significant. Breakthrough infections do occur among all the vaccines, and the rate is felt to be about 5 to 10%. Most of those cases, though, are asymptomatic or mildly symptomatic, so hospitalizations and deaths are notably lower compared to unvaccinated people who develop disease. There's no way around that. Some cases do have moderate to severe symptoms. We have seen that, but they're relatively rare. There was a recent Wall Street Journal review using collective state reporting data, found 1.89 million cases this year among 21 million fully vaccinated persons. That resulted in 72,000 hospitalizations and 20,000 deaths. Seems like a lot for those who are fully vaccinated. But virtually all those cases, those severe breakthrough cases, were heavily weighted toward the elderly and those with multiple underlying health conditions. So for those with breakthroughs who were in a younger population, really not significant at all. Now, the rate of long COVID or post-COVID syndrome for breakthroughs can still be significant. In one study, it was just as often as disease that occurred. Infection can be up to 17% of the cases, but they tend to be short-lived compared to those who got it from initial infection. So that's important to know. The CDC does monitor vaccine effectiveness via 5 different systems, depending on the population assessed. So they have monitoring systems for the VA, for long-term care facilities, for the elderly, and other populations. we've seen that after 7 months, efficacy does seem to drop with the vaccines. However, the hospitalization rate has remained stable. So we are not seeing an increase in hospitalization rates at all to speak of, any higher with the breakthroughs from the vaccine, which is very important to know. At first, we thought the J&J vaccine didn't hold up well compared to the two messenger RNA vaccines. The feeling was maybe one shot was not enough and you needed two. But interestingly enough, immunity has appeared to increase after month 8 with the J&J, and it's the mRNA vaccines, the Pfizer and Moderna vaccines, that aren't holding up after 8 months. So for people who typically got the Pfizer or Moderna vaccines back in January, February, March, they did great over the spring and summer, and we were actually seeing big drops in cases. But after 8 months, come the early to late fall, all of a sudden we started seeing cases, breakthrough cases, in those who were vaccinated. So there is suggestion that the vaccines were wearing off, and hence the need for the boosters. But again, you have to understand that even with those breakthroughs, we're not seeing severe diseases. The J&J vaccine uses an established adenovirus platform, whereas the mRNA technology is brand new. So we don't know too much about it. We don't know what the right dosage is, or the spacing, or the number of doses to give yet. And we're not going to know this for 3, 5, 8, or 12 months when we can look back and see what worked retrospectively. Normally it takes 5 to 7 years to determine these issues, but we didn't have that luxury here. We also don't know how neutralizing antibody levels actually correlate with actual immunity, which is why we don't use antibody testing and determine someone's immunity level. We also don't know or can't measure T cells in immune status. So there's a big argument, why can't we just do antibodies to see whether we're immune or not, and whether we need the vaccine? But right now we can't correlate levels. We don't know what the right antibody number is that correlates with adequate immunity. We just don't know that. So should we now be designing new vaccines against Delta or future mutations like Omicron for better or more long-lasting protection? Are we going to continue to tweak these vaccines forever? We do know there's a downside to that. The technology is there, but we're still trying to figure out if that's going to be a benefit. Like I said, some strains like Beta, Gamma, Delta are less protected from their vaccines, but they can't compete with Delta's increased transmissibility. And mutations like those with Omicron may still not be enough to overcome the impact of vaccines to prevent severe disease. So I think even though the vaccine companies are working on new vaccines, I think it's way too early to say that that's the way to go or we're going to need that. So for now, boosters will likely provide adequate protection against breakthroughs. And while the rationale is obvious for the immunocompromised who are less likely to mount or retain adequate immunity with standard 1 or 2 shot series, the benefit is there for all persons regardless of age, over 18, or those with medical comorbidities, if any. And I can tell you, I've personally seen people who were fully vaccinated and got breakthrough infection, and those breakthrough infections were, in some cases, fairly significant. It's too soon to say what the rate of breakthrough, if any, is seen following boosters, but right now we're not seeing any breakthroughs to speak of following boosting. So perhaps this will forestall the need for any further boosters, God willing. How about Dr. Elshinawy already mentioned transmissibility, and we do know that even though the viral load may be just as high in vaccinated people who get exposed to someone who's unvaccinated, it doesn't stick around very long. 3 to 5 days versus 15 to 18 days for someone who did not have the vaccine. There's a lot of dead virus there, so the transmissibility is short-lived and may not be as significant. So that's important to keep in mind. We know that vaccination following infection does have clear advantages, but what about those who had disease and are fully vaccinated? What's the breakthrough rate there? That's the hybrid immunity we're talking about, where you have infection with 1 or 2 vaccines. As of now, we don't really have any information on that. but the breakthrough rate is really low. So for people who have disease and got vaccinated, we're not really seeing any breakthroughs there to speak of. If the breakthrough rate is low, are boosters really needed for this population? Let's say somebody had infection and they had one dose of the vaccine. Are we going to mandate boosters for them? A lot of experts feel that the infection actually represents one dose of vaccine, and another dose or another 2 doses represent a fully vaccinated person or boosters. So in effect, the hybrid already is boosted. This is a pretty pertinent question, since we seem to be moving in the direction of requiring boosters to participate in certain societal events. We may redefine what fully vaccinated is beyond the just 1 or 2 doses with what we have now. And you can make the argument, well, if someone had hybrid immunity, do they need that booster? So up until now, we ignored infection as part of the criteria to be vaccinated. It's really going to be hard to ignore that for people who had infection and 2 doses of vaccine. And to require a booster for those people, it would be an understandable point of contention. With all that in mind, how does the introduction of the Omicron variant fit into all this? Like I said, as of now, very contagious, but mild. We are not going to know for another 7 to 10 days what direction we have to go in with this. So I think we'll know a lot more then. But until then, I think it's very important for those who should get the booster to do that, because as of now, Delta is still the predominant virus. It's the one that potentially can cause the highest morbidity and serious disease, and that's what we should be working on until we find otherwise that Omicron will overcome that. But right now, we don't have enough information to justify that.
Thank you, Dr. Barnish, again. That was very, very informative. If you want, you could just mute, sorry, because there's some feedback. Thank you. So our last very brief section before we go on to questions and answers, I want to just give you hopefully give you a few silver linings, but just one more silver lining to this pandemic, especially with this new variant scaring people and putting them in a panic. And I really hope that Dr. Barnish's discussion put some people at ease. He certainly put me at ease. So I really appreciate that. So I wanted to just very briefly go over new COVID treatments that are on the horizon. We're talking as of tomorrow, actually. So we didn't plan this about the scheduling of this webinar, but it just worked out that way, that the approval just came in today for one of the COVID treatments to be available tomorrow. So just to let you know, before these new treatments, as pulmonologists and infectious disease specialists in the hospital, we have been limited in terms of what we can use to treat COVID, especially at the beginning of the pandemic. But as the months went by and we learned more about COVID and what it does to the body, we've used different things such as steroids and blood thinners, infusions, injections, and clinics with monoclonal antibodies. Obviously, oxygen. Some people needed ventilators. Some people did well with that treatment. Some people obviously did not. In this country alone, we have lost over 700,000 people to COVID. So that's a crazy high number. And I think I know at least a few families who have lost loved ones to COVID. Unfortunately, the treatments that we had were very limited, and it depended on the person with different risk factors, how they were going to progress, improve quickly, or really have horrible life-threatening complications. Now we have 2 companies, Merck and Pfizer. Pfizer's making out really good during this pandemic, I have to say. But those 2 companies have 2 different drugs they have developed that they have put through trials and have been seeking FDA approval for. And the Merck one, the name is Molnupiravir, that has actually gained approval to start as of tomorrow. It has been shown to reduce the risk of hospitalization and death in high-risk unvaccinated adults by 30%. Actually, the UK already approved it in early November. They've started using it. But for the United States, we can start using it tomorrow. The Pfizer drug, more promising, has reduced risk of death and hospitalization by 89%. So that is crazy high and very, very impressive. Now, the people that can qualify for this medication, okay, are people with COVID. They have to have symptoms, and they have to be treated within the first few days of the infection. Sounds easy and straightforward, but as all of you, I'm sure, have noticed, it's not that easy to get tested and get your results in real time. So if you don't get tested for 5 days into the infection and then get your results 2 to 3 days later, it might be too late to get this treatment, this potentially life-saving treatment. So the key is to get tested as soon as you think you have a symptom of COVID, and then you would be a candidate to get this, this treatment at home. And that's the big difference here. This is the first time that we can actually give a COVID treatment at home. You do not need to go to the hospital or to the clinic to get it, or an infusion room. You could get this at home, and you would be treated for just 5 days typically with this antibiotic, if you will, but it's an antiviral medication. And you would take it about a couple of times a day for about 5 days. And they have approved it for people who are at high risk for complications. What that means is people with medical problems that put them at risk for complications, such as high blood pressure, heart disease, diabetes, congestive heart failure, obesity. We've noticed, now we have a lot of data, a lot of months, unfortunately, treating COVID patients, and we noticed that those types of people with those type of disorders tend to do worse with COVID. So those are the people that we're going to try to treat very aggressively at home before they develop the shortness of breath, before their oxygen starts to drop, before they have to be taken to the hospital to be possibly put on a ventilator. So we're trying to prevent all of that. And these drugs look very promising. The early data shows, again, the Pfizer one looks more promising than the Merck one. But I think future studies on these drugs may also look at the possibility of combining the two drugs, because they actually work in different ways on the virus. They both will inhibit the virus from making clones of itself, but they do it in different ways. So that's possible that you can actually give both drugs to a patient, again, potentially if the studies show that they're safe to do that, and kind of get at the virus at two different angles, as we do in cases like HIV, for example. As you guys know, we treat it with more than one antibiotic. With things like tuberculosis, we treat with more than one antibiotic. So it would be very similar with this. Again, I'm just throwing it out theoretically that possibly be another opportunity for these two companies to work together to say, can we combine our drugs and make for almost 100% effectiveness? That would be kind of wonderful. The other bit of good news is that the way these treatments work, it would not be a problem with this new Omicron variant. So even if this Omicron variant did come to the United States, and it most likely will, and gets a lot of people sick, we're thinking that these medications will also be effective. And Pfizer already came out and said this should not interfere with the medication treatment efficacy. So that's also very, very promising news. And for doctors like ourselves who have been treating COVID now for 20 months, we're very excited about this treatment, and that we have more options to help our patients hopefully not get to the hospital and not die of this infection. And I'll leave it at that positive point, and then I'm going to turn it over to our student, Dr. Melvin, and to see if he has any questions for Dr. Barnish and myself.
No, that was great. Thank you so much. And we had a ton of questions. Thank you to everyone in the audience who's participated and asked and chimed in. One of the very early questions we got was from Cindy, who asked, will her 8-year-old, who's going to be completing his vaccination set this Friday, he's already had his first and now will receive a second, will that 8-year-old child require a booster in 6 months?
You want me to take this? I think if I had to guess, I would say probably not, only because we're finding that young people's immune system is generally very, very robust, and they tend to have a much stronger antibody response than older people, especially as you get above 65. So the booster may not be so necessary for younger children. We're going to get more data as we move further away from the trial, because they keep checking the antibodies on the children that were enrolled in the trial. And so they'll be able to tell us way before the 6 months come up for your boy, if we actually do need to give boosters, because they'll know how much the antibody titers have waned. And they'll probably make a policy that says for those children who are immunocompromised for some reason, they may need to get a booster. But if someone is healthy, regular kid, not on, God forbid, chemotherapy or chronic steroids or anything like that, I would not think they would need a booster. Just an educated guess.
Thanks, Dr. Elshinawy. That was great. And we do have a question for Dr. Barnish. Considering the fact that there aren't any specific guidelines for antibody levels that would deem immunity, is there an acceptable antibody level or disease marker that would signify protective immunity, or how would we otherwise define a herd immunity where people are safe?
Right now, we don't have a number, a neutralizing antibody level or number that we know correlates with physical immunity. And the only way we're going to be able to do that is go out 6 to 12 months and then compare cases with the levels of antibodies, go backwards and see. But going forward, we don't know, because this is a unique situation. So we can't match a number to physical immunity at this point. The information is just not available.
Understandable. And quick question for Dr. Elshinawy about myocarditis. How do we identify high-risk individuals, and what are some of the recommendations for managing these patients who have myocarditis post vaccination?
How do we identify children who are at high risk for myocarditis, or
Any individual who's high risk?
Okay. So, I mean, this is the first time we've given messenger RNA vaccines to children and adults, for that matter. And I was just basically relaying the data that shows that the incidence of myocarditis and pericarditis was extremely rare in children who received the vaccine, as compared to those children who just got the COVID infection and had not been vaccinated beforehand. If someone does develop myocarditis or pericarditis due to either the vaccine or due to the infection, they should be promptly referred to a pediatric cardiologist, because they would be doing the monitoring and the management. So this is not something I would definitely handle, or a primary care should handle. This should be a pediatric cardiologist who should be handling that child and seeing them to complete resolution.
Got it. Thanks for clearing that up. And looks like we have time for about one more question. And this is up for either of you. In terms of holding effectiveness against different strains, do you believe that we will be able to achieve that with Moderna or Pfizer, and which one is more effective?
I'll take it. I think the technology is the same with both vaccines. So it's really going to be difficult to say which one is better than the other. We look at the technology, not necessarily the maker of the vaccine. So I don't think it's going to make a difference that way. It's really hard to predict again, but there are different ways to test to see how effective they are. We do know that with the Omicron, we only need about 24 days. We have the blood from patients who have it. We're able to match it with the vaccines, and we can make a determination within a couple of weeks how effective they are. So that's how great the technology is now. We can really figure out in a short period of time how effective they'll be.
That's very remarkable. Thank you for that answer. And we actually have time
Melvin, if there are a lot of, I'm sorry, if there are a lot of questions and people are still holding on for maybe 2 more minutes, you can ask more, because I know people have been holding on maybe to get their question answered. I personally don't mind, but maybe just a couple of more minutes.
Absolutely. No worries. I like this. I'm learning a lot. So, and thanks for that answer, Dr. Barnish. And Dr. Elshinawy, for you, there was one question about treatments. Would monoclonal antibodies be preferable over oral antiviral agents?
The antiviral agents right now that I just talked about so far look far superior to the monoclonal antibodies that we have, and the monoclonal antibodies kind of, at least in my experience and from what the data shows, has been a hit or miss. It's been helping some people shorten the duration of their illness and the severity of their illness, and maybe help prevent hospitalization. But the data from the antivirals is so much more robust and very impactful and very exciting. So I would, if I had to choose, I would definitely pop the pill.
Absolutely. And that's a good way to put it, pop the pill. And while we're on the topic of new and developing things, Omicron being one of them, is Omicron being picked up on rapid tests? And if so, with new variants, should we be considering updating our testing for screening?
Well, right now, the PCR tests, which are not the rapid tests, but the PCR tests are picking it up immediately. So when we run the test, we know right away it's the Omicron, and that's how come we've found so many cases in such a short period of time. I haven't read about the rapid tests being done, whether they are picking up the Omicron. I would assume they are, but that's something that's just not been out in any reports yet, so I don't know. But certainly the PCRs will pick it up very easily.
Nice. And honestly, that's about the majority of the questions we have. Some of them were answered beautifully during our discussion. You know, one big thing that you mentioned, Dr. Barnish, was tweaking the vaccine wouldn't be as beneficial. And you did speak to that fact that we do continually update our screening processes and treatments. If anyone else has any questions, feel free to contact us outside of this via email. You can also find the alumni webinar series on our website. And again, if you have any more questions or require clarifications, I'm sure that our panelists would be happy to answer your questions offline as well. Do you have any other thoughts that you want to share, Dr. Elshinawy or Dr. Barnish?
I just want to clarify about tweaking the vaccines. Not that it's not necessarily beneficial, but it wouldn't be helpful if we continued to do that in the long run. It would only be helpful if it turns out that a new variant caused severe disease. But if it didn't, then it may not be beneficial. I just want to clarify that. So the tweaking, it depends on how bad the new variant is. And again, to continually do that is probably not in the best interest in the long run.
Okay, no, I don't have anything to add. I want to turn this over. Thank you, Melvin, so much for helping us with the questions. It's always a pleasure having you along for the ride. I'm going to turn this to Dr. Iannizelli to close us out. And thank you again for everyone who joined us today.
Thanks, Ashgan. And I have to apologize in advance. I'm home here with my special needs son, Nick. He's very excited about a movie that he's watching. And so he's in the next room. So if you hear some background noise, that's Nick's joy. Thanks so much, Dr. Barnish. It's so wonderful to see you back on campus. It's refreshing to see you here. Dr. Elshinawy, thanks for all of your hard work. This is the second COVID webinar that you've done. You had done the initial one when COVID was just becoming an entity in our vocabulary about, I guess, almost a year and a half ago that was. And thanks, Melvin, student Dr. Ways, for your moderation. I'm Dr. Andy Ianzelli. I am the president of the Rowan School of Osteopathic Medicine Alumni Association. And I want to thank all of you for attending our webinar this evening and for staying with us. We tried to change the timing of it so that it might be more conducive to everyone's schedules, wouldn't be during work hours, and we had a great turnout. So thank you so much for all of that. I hope this was really helpful for you guys as it was for me. I have over Thanksgiving holiday, I was down in North Carolina and I had 2 cousins who were in the hospital with COVID on high flow oxygen. And so this topic is really pertinent to my family and me personally right now. For those of you who are wondering, I saw a couple of questions about this. This has been recorded and the session will be available through posting on our RowanSOM alumni page sometime next week. So please look for that for those of you who are interested in that. And also I'd like to thank our alumni webinar advisory committee. They meet on a regular basis to try to determine what topics might be relevant and interesting for the alumni at large. So I appreciate all the hard work that goes into that group, as well as the SOM team from the Office of Student Affairs and Alumni Engagement and Advancement for their contributions to these programs. The webinar series started about a year and a half ago when everyone started Zooming, when this became a regular part of everyone's lives, and it's been a wonderful success. So thanks everyone for their support of that. We're appreciative for all of your hard work. Brittany, I believe, is going to be putting up some slides that have our social media links. So feel free to join us through liking us on Facebook, as well as following us on Instagram. We're always looking for topics that might be interesting to have as future webinars. So if anyone has any suggestions in that regard, please feel free to reach out to either myself, to Dean Michichi, through the email that was provided with this program, or in the chat box if you have anything that you'd like to share right away. And we'll take that into consideration when we determine what programming we'll be offering in the future. Also, if you would, in the honor of Giving Tuesday, if you would be interested, of course, we would love for you all to exhibit your generosity by using the QR code that you see here on your screen. The funds that are collected through Giving Tuesday will be going to provide scholarship opportunities for our students. And so we would be eternally grateful if you feel so moved to make some type of donation. So in closing, thanks everyone for your time. Thanks, Dr. Elshinawy. Thanks, Dr. Barnish, again, for sharing your time and your expertise on this topic that is so entrenched in our lives right now and for the foreseeable future, unfortunately. And on behalf of the Alumni Association, I'd like to extend our best wishes to everyone for happy holidays. And now more than ever, I hope you exercise and appreciate and enjoy good health in the new year. Take care, everyone. Have a great evening.
Thank you. Have a good night, everyone.
Bye-bye.